And now I would like to introduce Dr. Megan Penner. Megan is a scientist with the expertise in all things omics. She is also the National Project Manager at the Environmental Determinants of Adult Autoimmunity India study, and played an integral role in establishing and expanding the cohorts and leading the scientific efforts in there. And Megan will be moderating our next session.
Good morning, everybody. Thank you so much to JDRF for giving me the opportunity to chair this session, which is titled Progress Towards Early Diagnosis and Primary Prevention Then and Now. This is a really great session to chair because I don't actually have to deal with questions. So as Dorota mentioned, if you have questions for our speakers, please put them into the Slido or write them on your pads, and we'll have a chance to address your questions during the panel discussion. So without further ado, I'd like to invite our first speaker to the stage. We have 6 great speakers today, and I'm really privileged to call all of them friends. So first we have Professor Jenny Couper. Jenny Couper is a practicing paediatric endocrinologist, and she currently leads the discipline of paediatrics at the University of Adelaide. Her clinical research is focused on 2 areas of type 1 diabetes, the prevention of type 1 diabetes. I think she wants me to stop speaking. She's also focused on the prevention of cardiovascular complications in children with type 1 diabetes. Jenny is the lead investigator for India, and she's also a co-investigator on INIT-1, INIT-2, ADIT and the BANDIT trials. So thank you very much, Jenny.
Thanks, Megan, and thanks, Juvenile Diabetes Research Foundation, for inviting me to speak at this sort of normal symposium, really. Just the first 1,000 days of life and implications for primary prevention. So first, I'll be talking a little about the early origins, then about the India cohort that we've heard mentioned, then in the development of the pancreas, when do we think endocrine and excrum function begins to decline, primary prevention trials and those in progress, and a little bit about progression in very young children. So IgE antibodies appear very, very early in at-risk children. And this is the TEDdy data, but in Australia we have similar data, very slightly later peak than Europe. And with this in mind, it certainly it shows us that something is happening very early in life. And interestingly, if you look at the autoantibodies that people at risk of type 1 diabetes are also at risk of, we first have IgE antibodies, then celiac and pernicious anemia autoimmunity, and then later peaks for thyroid autoimmunity. And I don't think we quite understand why there are the differences yet. So the early origins of type 1 diabetes is a concept applied across much of medicine, whereby adaptations to antenatal life modify offspring health, both in the first generation and in future generations. An interesting Dipnovan, which is a new pregnancy cohort, is actually going to investigate the grandparents as well. So India, the Environmental Determinants of Autoimmunity, set out to recruit 1,500 Australian children with a first-degree relative with type 1 diabetes, and to see what the early life exposures, their effect on the development of autoimmunity, and as such was the first and also is the largest at-risk type 1 diabetes cohort followed from pregnancy, proposing that multiple environmental factors in early life interact by the omic systems to increase the penetrance of type 1 diabetes genes, leading to autoimmunity. So key investigation opportunities are obviously the early life determinants back from pregnancy. Because about just under 2/3 of the mothers in the study have type 1 diabetes themselves as the proband, the impact of type 1 diabetes in pregnancy, mechanisms of maternal protection, maternal and paternal transmission of risk genes, and, for example, the gut microbiome, the isolation of antigen-specific T cells before IELTS autoimmunity, and monitoring and biomarkers in the very young children progressing. And so about 55% of those eligible and approached came into the study, which is interesting given it's a demanding study through to 10 years of age, demanding observational cohort with no intervention, and giving us, of live babies, 1473, born to just over 1,200 mums, and father, mother, infant triads of about 1230, and they've been followed for just a little over 5 years of age. So a lot of biological samples. The unique ones, of course, are particularly the ones in pregnancy and perinatal, and those from the father and the sibling. So we have a large biobank and about 70 to 75% complete, supported by validated questionnaires, reasonably comprehensive, and then monitoring with continuous glucose monitoring in the children, and hopefully also we're getting glucose monitoring data from the mothers with type 1 diabetes. So interestingly, the parents in the India cohort are not so different from reproductive age parents in the Australian population. You can see this high rate of obesity we have across. This is not overweight, this is obesity. A little more in India, were born in Australia, a little bit higher socioeconomic status, and just notice that the mothers, so I get the little point here, hemoglobin C in India was a little bit lower than that report from Australia. We have some nice data, I think, from Australia on caregiver and young children's experiences. These were children over 3 years of age, led by Dr. Kelly McCorm, and they may not be quite as happy about it all as their families, but it was some very interesting data. It's always slightly difficult in these very young children, particularly requiring some parental help. But the correlates are not so strong between parents and children, and we learned a lot from this and modified some of our practices accordingly. So at present, we have about 9% of children who have developed persistent IELTS autoimmunity, and notice that the 22 children who have developed type 1 diabetes, as Dorota mentioned, have a very low risk of DKA, just one mild DKA. And these are very young children who normally have about 50% risk in Australia at 2.6 years. In terms of the antibodies, you can see the multiple antibodies shown in the orange line on the left are plateauing earlier on estimation than the singles. And if we look at which antibody comes first, like the other large cohorts internationally, the insulin antibodies are first in the young children, then comes GAD with or without insulin. But the purple shows the zinc transport antibodies. This is relatively unique data in as much as some cohorts have not looked at zinc as a first antibody and waited until an antibody was already present. And so certainly by over 7 years of age, zinc transporter 8 antibodies are the most common first appearing antibody, which is interesting. So this is the TEDdy data where 2 patterns were seen in a much larger number of children, suggesting 2 patterns of onset with the very young children, showing the red peak in insulin antibodies and then the GAD antibodies coming in later and then taking over, as it were, with some interest as to whether there are different influences driving these 2 patterns of autoimmunity. We could also look at transplacental transferred antibodies, because in the mothers who have type 1 diabetes, the insulin may well be to the insulin they're taking, but obviously without antibodies, this is real autoimmunity being transplacentally transferred, going right through to about 15 months of age, so relatively later, but certainly no relationship between this and the risk of autoimmunity at this stage in their offspring. So India's got some unique samples, as I've mentioned, which we see as very precious, but it's a relatively small cohort, 1,500. and with a relatively short duration of follow-up. So our numbers of outcome are still relatively low and relatively low power, but we're do have opportunities, we think, to join up with some of the larger cohorts to connect with them in this sort of format whereby signatures and biomarkers are seen to be important for risk of autoimmunity in the larger cohort, and then can be applied to the India cohort, looking back then at the prenatal exposures, such as hyperglycemia and pregnancy, etc., for maternal protection. So with the pancreas developing over the first 1,000 days of life, when does endocrine function, excrum function begin to decline in the development of type 1 diabetes? In terms of endocrine function, beta cell dysfunction, we traditionally saw this happening probably after autoimmunity had developed, although some recent data suggests that maybe earlier. This is from the GPAD point study, the oral insulin study of tolerance in 1,000 children, and they looked at glucose before feeds, non-fasting, and then about 30 minutes later, and showed in all the children this sort of small nadir between 12 and 18 months of age. I put our units on the left there to orientate us. And then in the lower figure on the right, the line represents IgA antibody seroconversion, and you can see the darker lowest curve. There's some rise, but these are very small increments, as you can see from the y-axis, but some rise possibly before seroconversion that continues. So this idea, is there a beta cell insult close to seroconversion or even perhaps before? And this is data from the India CGM study in the children without autoimmunity and controls. And Dr. Ebony Haynes, who leads the study, has kindly given me the data from the first CGM profiles, although these children are followed longitudinally. And they've had autoimmunity on average median of 2 years. But you can see here our mean blood sugar on the left is little different, 6.1, 6 and 6, but between across multiple single and controls. But the big difference is, as is seen in other studies, in the standard deviation score in these children with increased variability, so that their time in range in the multiple children with antibodies is significantly lower than in controls. So Mark Atkinson's group from the University of Florida Diabetes Institute has pioneered the concept of the contribution of the Excrum Pancreas potentially to the pathogenesis of type 1 diabetes. It's well established now that the pancreas volume in type 1 diabetes is smaller, and the excrum function is within the normal range but lower, and there's also histological changes. But the longitudinal data is lacking, and particularly in relation to the timing of the onset of autoimmunity and in relation to the beta cell dysfunction. So we think we have some opportunity to do this in India. We can't do MRIs in young children. They require GA, and ethically that wouldn't be acceptable. And so this is just using area on ultrasound, but we can see a significant difference between young children with type 1 diabetes on the left, a child, and on the right, a matched control. And just looking to see some overlap, as you would expect biologically, but we certainly can separate them in significance. And then using fecal elastase, which is probably the best measure of excrum function, we can also separate them, although these readings are all in the normal range, and these children don't have excrum dysfunction clinically. So we looked at longitudinally in about 30 progressors and matched controls, relatively small numbers and a kind of a mismatch of single, multiple and type 1 diabetes. But we think we can see some blunting of the normal rise in the autogeny of the pancreas and excrum function. You see on the left that normal rise in the first few years of life is being blunted, if not falling, and we're expanding this to larger numbers and collaborating with the University of Florida Diabetes Institute. So for prime prevention, the evidence and targets, remembering that this really includes the potential of reintroduction of protective factors that have been lost in the modern environment, and particularly with children with moderate risk genes driving potentially the increase. So there's maternal protection, viral and bacterial infections, weight gain and growth in early life, and the microbiome are the main ones present with evidence. So maternal protection, I think we're all aware of this phenomenon whereby if your mother has type 1 diabetes, your risk is significantly lower than if the father or your brother or sister. And there are a number of mechanisms proposed. The ones that India is particularly looking at differences in the transmission of parents' risk genes or other epigenetic changes in relation to the maternal milieu with type 1 diabetes. And then from Len Harrison's laboratory, some work which I'll show in the next slide underpinning this, the maternal milieu during pregnancy, whereby there is a pro-inflammatory microbiome developing by the third trimester in mothers with type 1 diabetes, which may enhance the development of the infant's immune system and act that way to protect. So this is the work underpinning from Len Harrison's lab and published, lead author by Alexandra Roth-Schultz, showing the bacterial functions in women with type 1 diabetes in the red are quite distinct from the women without type 1 diabetes. So you can see that left top box has increased production of the endotoxin, of a polysaccharide, and reduced in the box in the middle on the bottom line, short-chain fatty acid production. So a sort of pro-inflammatory microbiome that may actually, in fact, be beneficial. So maternal smoking has for some time been known to reduce the risk of type 1 diabetes in offspring, but not actually after pregnancy. So parents smoking for a child does not reduce risk of type 1 diabetes. And this is not very helpful in a public health sense, but it does raise the question, the mechanism of nicotine, is that it has some immunosuppressive effects potentially, interacts with the acetylcholine receptors on T cells, and may have some effects on inflammation. I'm just showing this partly because it has Australian data. This is data, this red one, the meta-analysis is from Dr. Ebony Haynes, led the study from Western Australia, and from South Australia, Dr. Mentrance Begum led this more recent study, all over with an odds ratio of about 0.75. So primary prevention trials in progress, the Global Platform for the Prevention of Autoimmune Diabetes, which is mentioned, their first trial was a primary oral insulin trial to look at inducing immune tolerance in young children from 4 months to 3 years of age to see if they could delay the onset of viral autoimmunity in young children. And results of this are expected in 2025. Then the Cynthia study, which is a specific probiotic intervention from very early, from 6 weeks of age to 12 months, and they're supplementing with Bifidobacterium subspecies of infantis, and I'll come to the data underpinning that, to reduce the development also of multiple antibodies or stage 1 type 1 diabetes in young children. Results expected by 2027. And underpinning this is the work from Teddy showing that in the breastfed child, this abundance of Bifidobacterium longum shown in the red on the heat map. And the subspecies infantis is a very efficient metabolizer of the sort of natural prebiotic in breast milk of human milk oligosaccharides, which converts to short-chain fatty acids, which may have some protective effect on the development of type 1 diabetes in childhood. So if we are to intervene from pregnancy, and we kind of see India's role to in part inform this, we'd have to know more about maternal infant transmission of the gut microbiome, which is complex, not surprisingly. This is work from Tommy Batten's laboratory in Finland, and showing that the transmission of maternal strains continues throughout infancy and is important for the assembly, but the contributions of the fathers and siblings are yet to be known. We hope to look at that in India as well. We went through the process of considering the design of an intervention trial from pregnancy, probably from the 3rd trimester. If, for example, we were using a resistant starch to more upstream rather than a specific probiotic to increase generation of short-chain fatty acids in the mother's microbiome, would that cross to the infant, and when would we measure that? To look at that. And I think while this study is not occurring and is not funded, we saw some interesting concepts and design of a pregnancy study. First, there are factors that you can't really control for in the endocrine microbiome, but you'd probably be wise to limit gestational age at birth to greater, that not being premature because of the complications of caesarean section in premature babies and the neonatal nursery environment, altering the microbiome quite substantially. And we also realised we'd have to stratify recruitment according to type 1 diabetes status, showing these quite distinct differences in the mother's microbiome during the third trimester. So it was an interesting exercise to go through, considering, but a trial that had a definitive, robust outcome measure, such as stage 1 type 1 diabetes, would obviously be international for primary prevention. I'm not going to talk about viruses. It's very exciting. The phase 1 study has occurred for this first multivalent human Coxsackie B vaccine, because Dr. Kim will be talking about that this morning. So the weight gain and risk of childhood type 1 diabetes in at-risk children, there's a high rate of weight gain, what we call weight Z in under 2-year-olds. We don't use BMI Z in the very young children, is associated with increased risk of developing type 1 diabetes, and this is particularly in evidence with children developing anti-GAD first, is what TEDdy extended our findings in this way. More recently, in the general population shown in Frida in Germany, BMI predicts progression to type 1 diabetes, and using a Mendelian randomization approach, childhood body size directly increases type 1 diabetes risk, shown from adults with type 1 diabetes, but interestingly not adult type 2 diabetes risk. And the effect of mothers and fathers' weight, I show those very high rates of obesity, which are not just unique to Australia, is not yet well defined, but needs to be investigated clearly. This is some while ago data from the Australian Baby Dive study, and showed that the children in red with weight Z scores above average, especially under 2 in the first couple of years of life, had an increased risk of autoimmunity. So finally, these young children have a different rate of progression to the first stages of diabetes, not surprisingly in a way. I hope you can see that okay. That figure was a little bit different on the screen, but this is work from TEDdy, and it's showing in the different age groups the spread from single to multiple antibodies. And you can see that the children under 1 in red, under 2 in blue, and under 3 in green are progressing more rapidly, and much of this progression is occurring within the first 2 to 3 years from getting their single antibody. So when following these children, you would see the rule of 3s. Children under 3 years need to be followed more frequently, and children should be followed for at least 3 years. If we look at the progression to type 1 diabetes insulin requiring, again, it's particularly the children, the 1 and 2-year-olds, who are progressing most quickly, in a way, not surprisingly. But it does mean that, trials of immunotherapy in this age group are difficult for a number of reasons: the age of the very young child and the rapid progression. And there have been few trials, hydroxychloroquine study, and there is currently the petite type 1 diabetes study that enrol very young children. But we can have lessons from other autoimmune and other inflammatory diseases in young children. And after the BANDIT study showing the success of baricitinib in recent onset type 1 diabetes, we looked at what's going on in the younger age groups. And in Australian centres are included these. So our colleagues down the corridor in gastroenterology and rheumatology and dermatology are actually using these disease-modifying therapies, as we mentioned last evening. And there are 2 trials in progress which have Australian centres in them, one for severe atopic dermatitis and one back down to 2 with severe ulcerative colitis. And there's been a recent, quite large study published for tafasitamab in children aged 2 to 17 years, and it's the largest reported trial of kinase inhibitors in young children, successfully treating and safely treating and well-tolerated treating arthritis in children. So in summary, the rapid increase over the last 50 years is driven by the modern environment in children with lower to moderate risk genes, has been shown in Australia. Islet antibodies appearing from early puts us back to looking at what's going on in utero. Environmental factors, including loss of protective factors, are likely to be ubiquitous and acting in combination. And if we can fully understand the role of these protective factors and reintroduce them into the general population, we may have a chance of slowing the increasing incidence. And primary prevention trials are cyclically underway. And it's probably a big road ahead, but if we could, it's very, very promising, the change over the last 5 years even. So thank you so much to our funders, because without JDRF and Helmsley Charitable Trust, you actually must see this, India simply wouldn't exist. Amazing team, which has been wonderfully consistent, and we're so proud of everybody in our India team, and our amazing families. Thank you.
Thank you so much, Jenny. Our second speaker this morning, it's my great pleasure to introduce Professor Marian Rewers. Marian is the Executive Director at the Barbara Davis Centre for Childhood Diabetes at the University of Colorado. I know this because I saw him in the stairwell. I did know that beforehand. Professor Rewers is the principal investigator of the large NIH-funded prospective cohort studies, the Diabetes Autoimmune Study in the Young, or DAISY, and the Environmental Determinants of Diabetes in the Young, the TEDdy study. He's also involved with the coronary artery calcification in type 1, the CACTI study, and the genetic and environmental causes of celiac disease. So thank you so much for joining us this morning.
Thank you, Megan. Good morning, ladies and gentlemen, and thanks to the JDRF Australia for giving me an opportunity to be here with you, celebrate the anniversary of CNR, Clinical Research Network, CRN, and share with you my very biased views on what's happening in diabetes research and clinical practice today. So here are my disclosures, and let's start from just a map. What do we know about the natural history of type 1 diabetes? The red line shows the beta cell function, the ability to make insulin. And it's normal when babies are born, and then something happens, and Jenny has introduced a lot of potential triggers that may start the autoimmune process in the islets that kill, the processes kill beta cells, insulin-making cells. And then, the ability to produce insulin drops below this red line, dotted line, which is the magic line below which we cannot control blood sugar anymore. There's hyperglycemia, and there may be a little bit of a remission in some cases, but generally it's a downslope. So the blood sugars, and I used with all the liberty CGM data to illustrate that the blood sugars are pretty normal in the phase of autoimmunity, but then towards clinical diagnosis of hyperglycemia and diabetes, they become a bit more erratic, which we call dysglycemia, minor excursions of glycemia. But what we know in the past, clinicians, as the beginning of type 1 diabetes is this picture, where a young child is admitted to a hospital with DKA, acute deterioration of metabolic status. And what happens next is chaos. Every day is different, ups and downs in blood sugar. You have to control it with insulin and potentially additional adjuvant therapies. But generally, it's a mess that leads eventually to complications. So there are those three phases of type 1 diabetes. For the first number of years, it's just an autoimmune disease. And then it becomes, on top of autoimmunity, a metabolic disease. And finally, it becomes a multi-organ disease with all kinds of complications that shorten the lifespan and quality of life. So my first suggestion in terms of paradigm shifts is that it's not childhood diabetes. You remember this historical term, it's really mostly an adult disease. Type 1 diabetes is diagnosed in more than half of the cases in adults 30 years of age and older. So sure, most kids who have diabetes have type 1, but most patients who are diagnosed, and a vast majority, perhaps 80–90% who have type 1 diabetes today, are adults. And we have a lot to do in this space. Let me just give you some ideas. So basically, this is the traditional kind of thinking about classical type 1 diabetes, diagnosed perhaps in early puberty. And yes, there are some rapid cases diagnosed in infancy or in toddlers, but most of the cases are actually following this trajectory and don't drop before this magic insulin dependence line until their 20s, 30s, or even 60s and 70s. So the problem is, at least in the US, maybe it's different in Australia, a lot of those young and older adults diagnosed with diabetes are misdiagnosed as type 2, given metformin and told, well, go see your endocrinologist a month from now, and they come back to emergency room with DKA. It has to change. Testing for islet autoantibodies to detect the autoimmune process has to become a routine in diagnosis of diabetes, any form, in adults. Now, Jenny mentioned TEDdy, and TEDdy teaches us many lessons, but one is when you look at the incidence of islet autoimmunity, it's very high in children up to the age of 4 or 6, and then it declines with age. And what we are seeing now at the late phases of TEDdy is that there are very few seroconversions at the ages 14, 15, and beyond. So the hypothesis here is, and very likely it's true, that there are very few seroconversions in adults. Basically, all future cases of type 1 diabetes develop autoimmunity by the age of 15 or 16. And then it's just a matter of time when they progress to clinical diabetes. In TEDdy, only about 40% of those kids with autoimmunity progress to clinical diabetes by the age of 15. And the remainder will do it in the next 3–4 decades of their lives. To kind of provide an independent proof of this hypothesis, here are data from autoimmunity screening in kids, ASK study in Colorado, where we screened thousands of kids, but also about 1,000 of their parents. And what we found was really kind of surprising, that the prevalence of multiple islet autoantibodies was exactly the same in kids, and sex, age, ethnicity, family history matched adults. So there are many, many adults walking the streets with multiple islet autoantibodies and single high affinity autoantibodies that are also predictive of future diabetes, waiting to be diagnosed, waiting to, not really wanting, but on the trajectory to be diagnosed with type 1 diabetes. Here are the estimates in terms of people diagnosed every year with type 1 diabetes, children and adults in the US. Those are the estimated numbers of children and adults, respectively, at stage 2 of dysglycemia, presymptomatic dysglycemia stage of type 1 diabetes, and stage 1, which is multiple islet autoantibodies. You can appreciate the magnitude of effort that we are facing today in terms of screening and identifying those people to help them either delay diabetes or stop the autoimmunity altogether. Okay, so what can we do in terms of primary prevention? and I can be brief here because Jenny gave an excellent overview of primary prevention trials. We have to act early, very early, before the environmental trigger happens. And what's happening now, we know that there are a number of potential triggers of the process, either in early infancy or even prenatal. And here are the clinical trials that have been done so far in terms of primary prevention, and the two trials that Jenny mentioned that are ongoing within the GPATS system. Now, please note that all of those trials have focused on diet, on oral intake, even oral insulin, maybe not diet, but it's oral intake. And none of them have worked so far. So my paradigm shift here is that we really need to think about a different intervention that happens very early in life, potentially in infants as young as 2 months old. And initially, the trials may be limited to kids with high risk, genetic risk for type 1 diabetes, and have two outcomes, islet autoimmunity and type 1 diabetes. You already know what kind of trial it is because Jenny told you. It's going to be something related to enteroviruses, a vaccine at best. And Teddy have contributed perhaps the strongest evidence to date in humans that the persistent presence of enteroviral RNA in stools is a very strong predictor of islet autoimmunity. Not a sporadic single infection, not 2 infections here and there, but the persistent presence of enterovirus in the stool is a predictor of development of islet autoimmunity. Now, Teddy, I don't have a slide for that, but Teddy is working very hard on showing that where the virus sits, where it persists. It does not necessarily persist in stool, but it persists in white blood cells, and most likely also in the pancreas. How do we know it? There's a very small N of 6 study from Norway where biopsies were obtained from young adults newly diagnosed with type 1 diabetes. And there are also data from NPOD and autopsy studies from the UK, all showing that there is a virus sitting in the pancreas, and more specifically in beta cells. In islets that have been inflamed, those islets show presence of VP1, enteroviral protein, and also enteroviral RNA. Those are not easy studies to do, but there is a growing body of evidence from other groups showing that the key factor in that tissue-specific inflammation and persistence is the CAR receptor, C-A-R, Coxsackie adenovirus receptor, which can facilitate infection of specific beta cells in the islets, and even more, after the virus establishes infection, then it tries to evade the radar screen of our immune system by mutating. There are new mutants created every minute during the enteroviral infection, and some of those variants have been shown to have very specific deletions in the 5 terminal end of the genome, which lowered the rate of replication and allowed the virus to establish persistent infection for decades. This is probably what's driving autoimmunity, and this is what we should prevent by vaccinating infants against those viruses. All right, so there's this vaccine. You'll hear more about the vaccine later today, so enough to say that the phase 1 study was conducted in adults in Finland. The vaccine was shown to to be safe and effective in terms of raising the antibody levels to the Coxsackie viruses, and now we hope it will be moved forward to phase 2 study in young kids. All right, paradigm shift number 3. We should not be seeing kids diagnosed or adults diagnosed with DKA anymore, because it's more than 90% preventable. If we have the ability to screen for alert autoantibodies after these environmental trigger acts and monitor kids and adults who are antibody positive, tell them what the symptoms are to watch for, teach them how to monitor home blood sugar at home, or use OGTTs or use CGMs. If we can do it on a large scale, which is not what's happening yet, we can prevent DKA. And DKA is especially a big problem in the US. Here are data from Colorado, where the DKA rates have been going up for the past 20, 25 years. And now more than half of kids diagnosed in the US are diagnosed in DKA. We can criticize US healthcare system for 2 days, but it's not the point. We have to do something about that. And the screening and monitoring is one way we can counteract. How many pediatricians are here in the room? Raise your hand, or clinicians, raise your hand. Okay, so I don't need to preach the obvious to you that DKA is bad. It's not only bad in terms of acute metabolic condition that can be deadly if not treated in time, but it has also very powerful effect on cost to the society and to the family, on psychological trauma that happens to the family and to the child, but also it leaves people who are diagnosed in DKA with much fewer insulin-making cells in their pancreas. So they start their treatment, their adventure with type 1 diabetes, which with a much smaller endowment in their pancreas. And we know it by looking at some data, for example, from large clinics like the Barbara Davis Center clinic. We followed more than 5,000 kids by their DKA status, and those who were diagnosed without DKA, you see their A1C, their average A1C, and it was before CGM era. Those kids were diagnosed since 1998, so historical data by far, but we followed them for up to 15 years. Without modern technology, their A1C was not perfect, but still much lower than for kids who were diagnosed with mild to moderate DKA, and almost 1.5% lower than those diagnosed with severe DKA. And it was still all adjusted for sex, race, insurance status, access to insulin pumps, all of those potential confounders. So we have to diagnose type 1 diabetes sooner with lower A1C and no DKA to provide the optimal prognosis for the future future life with type 1. And here is what, it's a busy slide, but I'll take you through all of those rows. Here's again the US. Tragic situation, 40 to 60% of kids now being diagnosed with DKA. Europe and probably Australia are doing much better. Only 20 to 30% of kids are diagnosed with DKA. But then studies like DAISY, TEDDY, TrialNet, they all were able to show benefit by screening for antibodies and monitoring kids, even without too much education about symptoms. Those studies lowered the rates of DKA to about 5–6%. And now the joint population screening programs in Germany and in Colorado show very similar rates. So we can prevent 90% of DKA cases. How does Frida do it? It's a study that started in Bayern and then also included 2 additional provinces of Germany. It screens initially kids 2 to 6 years old and now also older, up to 10, for multiple islet autoantibodies, and then follows those kids with metabolic evaluation and some education. And here are results of Frida to date. I would like to draw your attention to this lowest row. So here are kids who were not detected by the screening because they were positive probably for a single islet autoantibody, not for multiple antibodies, so they were not educated, enrolled in education, and 14% of all kids who developed diabetes, 169 total, were in this category. The frequency of DKA was like in the underlying population, about 25%. Here are the kids who were screened, and parents were told, your child is at high risk, but they elected not to participate in follow-up and education. And again, it was about 25% of all cases, future cases of diabetes, and there were some cases of DKA. But among kids who did enroll in follow-up and monitoring, there were only 2 cases of DKA, 2 out of about 100 or so cases of diabetes. So very good result in terms of preventing DKA. Ask and Colada has a different design. We screen initially using a very different set of assays, very highly specific and sensitive, using 5-plex electrochemiluminescence assay, including an autoantibody for celiac disease, transglutaminase autoantibody, and then we confirm it and monitor, of course, those who are persistent, high risk for diabetes. And the results are very similar to Frida results. When you monitor those kids who are antibody positive, regardless if they are multiple autoantibody positive, have single high affinity autoantibody, or even single low affinity antibody, you prevent 90% of future cases of diabetes. So we can do it, but the trick is to bring it up to scale, to really move screening from the research area and studies here and there to general practice. One more aspect. Kids who are diagnosed through those general population screening studies have much lower A1C when they are diagnosed. Data from ASK, the average A1C at diagnosis was 6.5% compared to 11.5% in our community controls. Now there's a smaller study funded by Helmsley within ASK called TESS for the early start study, where we use CGM monitoring unblinded. We educate the family just like we do it for new onset cases, and we start insulin at the first sign of hyperglycemia, which is detectable much sooner by CGM than by A1C. And in this test study, the average A1C at diagnosis of diabetes and start of insulin was 5.7. So 5.7 is a cutoff for dysglycemia. Nobody in the clinical practice today would start a kid on insulin with A1C 5.7. 6.5, sure, but not 5.7. Is this where we are heading in the future? Perhaps. We'll see if it's necessary and if it's cost-effective. Data from Frida, also A1C, much lower, 6.2, in kids detected by screening than in the general population, 10.5. And also, they have already presented Cpeptide levels, which are twice as high in kids diagnosed in Frida versus the general population controls. So it's not only the A1C, but more residual insulin present at diagnosis. All right. So how often do you need to screen to detect at least 80% of future cases of type 1 diabetes? At least twice during childhood. The first time around the age of 2 years, and you shouldn't screen for 2 antibodies or more, because you are going to miss at least 30% of future cases in the general population. Frida missed only 14%, but they haven't seen all of the cases yet. So you should really screen for even a single antibody and then confirm that it's persistent and follow those kids with single antibody for at least 2-3 years to see if they do or do not seroconvert for additional autoantibodies. But anyway, around the age of 2 and around the age of 6 is the bare minimum. So not 1 time, 2 times during childhood. And we have a publication in the pipeline showing that if you add third screening around the age of 10, you pick additional 10-15% of the cases. So maybe 3 times. But even if your child or patient was not screened yet and is 10 or older, it's still not too late to do the first and perhaps the only screening in life. Okay, so the next paradigm shift is the teplizumab, the first drug that FDA approved for clinical use, not for research use, but for clinical use. Now we have a proof of principle that such a drug can be approved, and if applied somewhere here, close to diagnosis, presumed diagnosis in the face of dysglycemia, it does improve longer-term outcomes like Cpeptide, A1C, and perhaps the risk of complications. The complications, of course, we have no proof yet. It's the teplizumab delays or improves, but if the A1C is good, it should be automatic. There are additional drugs in the pipeline. Very quickly, there may be a pharmacogenetic effect of HLA on the effectiveness of teplizumab, something to keep in mind and confirm in a larger study. But here is the map. There are so many ideas, so many drugs in the pipeline. And even in this room, I see at least 5 groups represented that are working on different approaches to prevention or delay of insulin dependence. It just happens that the teplizumab was the first approved, but and by the way, this is our first patient, 16-year-old, whom we infused with teplizumab at the BDC in April. By now, we have 5 of those patients and 9 more in the pipeline, so it's picking up. But there are additional possibilities. One is ATG that is being tested by TrialNet at stage 2, dysglycemia, and verapamil that you probably know very well, clinicians. It's a calcium channel blocker that has been used for ages in atrial fibrillation and hypertension, and most recently this spring, it was found effective in newly diagnosed patients in helping them to retain Cpeptide after diagnosis. Now, interestingly, we don't know what is the real mechanism of this drug. It's probably not the calcium channel blocking. Some people believe it's a TEC-SNP pathway, but the field is divided whether the TEC-SNP pathway is important in beta cells or in T lymphocytes in the immune system. So this is now currently under investigation. And just to show you in picture what that study found was that at the baseline, those were values for Cpeptide and the area under the curve at baseline, a diagnosis, and then at 1 year after diagnosis. So in the verapamil group, it has not changed. It looks like the average was the same a year later, while it dropped by about 1/3 in the placebo group. It has to be confirmed in another study and even more at stage 2 and stage 1 presymptomatic diabetes, but it's a pill. It's not a 14-day infusion like teplizumab. So most people would be more willing to experiment with a pill once a day than with teplizumab. All right. I'm heading towards the end of my talk, and just to remind all of you who don't have type 1 diabetes how hard the life with type 1 is. You are balancing all the time between highs and lows, at the verge of going in coma or something bad like car crash. Of course, over the time, it goes to the background and you learn how to balance. But it's still a tough life, and the life expectancy is still shorter by 10, 12 years compared to the general population. So the paradigm shift number 5, and this is my last paradigm shift, is technology, the impact of technology. Tell me, who remembers using urine testing in your patients? Raise your hand. Yeah, this is how I started my career in diabetology. Here, those were the tests at our disposal. And you can see the history, how pumps and insulin analogs and CGMs came about, and we are now living in a great era compared to the past where there's a competition. There are at least 5 companies competing in the pump space and CGM space, and we are heading towards very small automated AP systems. But as of today, well, this was actually only 10 years ago. This is how I saw my job as a pediatric endocrinologist. We were telling families, well, shoot as low as you can with A1C, but without your kid having severe hypoglycemia. And these were the tools we had at our disposal. And now, there are multiple studies, so I can present only one today. And this is in the youngest kids, 2 to 6 years old, where the group compared effectiveness of having all of the tools at your disposal. Here, pump or multiple injections, sensor, but not working together, not talking to each other, versus those systems talking to each other. And those are, again, very, very young kids. This is the difference in time in range. Time in range, the higher time in range, the better glucose control. So in the intervention, in the intervention group, look, during the night, almost 100% of kids were in range, safe. This is what a lot of parents lose their sleep over, that their kid may crash during the night. Using those hybrid closed loop systems, you can actually give the parents and the kid their sleep back and the safety. Those are very significant differences, and not only during the day, but especially during the night. So on the bigger scale, when we look at the US data from T1 Exchange registry, you can see that it really doesn't matter that much if insulin is infused through a pump or injected from syringes or pens. Those are the best time in range. Sorry. No, this is A1C, and forget, this is A1C. So the best A1C is really when people use CGM, regardless with or without pump, and then pump alone improves a little bit the A1C control versus MDI, and this is across the lifespan. So of course, teenagers are our biggest problem, but technology helps patients of all age across the age span. All right, and this technology should be initiated as soon as possible after diagnosis. Here's the data from BDC. Our patients, we looked at the effect of timing when you actually add CGM to the tools, and if patients who never started using CGM had worsening A1C over the years. Those who started on CGM 3 years after diagnosis kind of stopped this deterioration at that point, but never achieved the wonderful levels of 7.5 if CGM was started within 1 year after diagnosis. Well, this is old news. Now we start CGM within the first week. We pretty much try not to bother families with multiple testing, finger poking, and start CGM right away. And they are so grateful because they can see. Finally, it's not like a fog and finding your way in the dark. You can see where the blood sugars are heading. All right, and just this level of improvements that you saw on the previous slide gives you this type of reduction in long-term complications if it can be sustained, even at only 7.2 level of A1C for 6 years, extrapolated from the DCC edict data. All right, so I wish I had the 6th paradigm shift, but it's not ready yet. But I could not resist temptation to say a few words about transplantation, islet transplantation, because everybody who has type 1 wants to more permanent solutions than just the CGM and insulin pump. And as you can see, it's a difficult road, many obstacles. We don't have time to go over all of them, so I will focus on positives today. There's a lot of promise in terms of application of allogenic or autologous stem cells. And allogenic can come in form of human embryonic stem cells or induced pluripotent or iPS cells. And then, for those, you have to differentiate the cell and then differentiate it again. So it's a little bit of a longer process. Embryonic stem cells are not differentiated, so you just have to differentiate them into beta cells. Okay. Now, you've heard probably names like ViaCyte and Vertex, so I wanted to put them on this map here, what those companies have done. So those are the steps that one has to go through to move from pluripotent cell to at least the pancreatic progenitor, if not to the step of immature, almost ready to go beta cell. So many steps that require very controlled and clean environment and take some, not hours, but days to achieve. So ViaCyte transfused or transplanted pancreatic progenitors. And to make a long story short, it didn't work well. I mean, it was a great idea, but it didn't work. The Vertex company went further, and there are some downsides, like inefficient process of generating those cells. And but there are many advantages. Those cells are more likely to be responsive to glucose and actually release insulin when you need it. This study called Vertex 880 is supposed to enroll 17 patients. It has enrolled 6 so far. 1 dropped out. 2 have completed 1 year of follow-up, and those 2 patients show some promise. But from those numbers, you can guess how long it's going to take for this approach to be FDA approved. It's still not a paradigm shift, not available to your patients, yet it is a very promising approach. And to give ViaCyte some credit, they came up with novel ways to avoid immunosuppression. The Vertex approach still requires immunosuppression for life. The ViaCyte, using CRISPR technology, came with this particular encapsulation that provides direct vascularization and oxygen flow to the transplant and does not require immunosuppression. So Vertex, I believe, bought ViaCyte, and now they created one company. Let's hope that it's for the benefit of the field and that we will see the results soon. Autologous stem cells also can come from a pluripotent approach or from less, and this is good for one more reason, that you don't have to bother with typing for HLA and other compatibility markers that affect the survival of the transplant. So this is still a very good approach, although not as actively pursued yet as pluripotent cells. All right, so there are problems that we can skip. Summary. Those are the 6 paradigm shifts, 5.5 if you will, that I tried to share with you today. And once again, type 1 diabetes is not childhood. It's all ages and mostly affects adults, and it's often misdiagnosed in adults. There's a promising Coxsackie vaccine, and I hope there will be more, not just one. Screening for islet autoantibodies can prevent DKA, can allow us to diagnose diabetes with lower A1C, with more Cpeptide, with better futures. And teplizumab, still there are multiple practical questions, but the one thing is certain, that it can delay the onset of insulin dependence. Hybrid closed-loop system technology already improves quality of life and outcomes in type 1. And there's slow but steady progress in islet cell transplantation. I would like to thank, before I thank anybody, here's a warning that paradigm shifts come with a cost. And each of those, you can probably immediately calculate the additional cost to the society to actually implement those paradigm shifts on a large scale. So when we go through those, let's not forget about what has been working well for us and retain those elements in our diabetes care, not just put everybody on best technology or try to transplant islets to everybody. Okay, so I'd like to thank my team at the BDC, more than 220 people strong, and most importantly, to all of the kids and adults who have participated in studies that got us here, and to all of our sponsors, including JDRF, Helmsley, industry, NIH, and other national funding agencies. Thank you.